Welcome to Critical Matters, a sound podcast covering a broad range of topics related to the practice of intensive care medicine. Sound provides comprehensive critical care programs to hospitals across the country. To learn more about our programs and career opportunities, visit www.soundphysicians.com. And now, your host, Dr. Sergio Zanotti.
It has been almost 25 years since the publication of the Institute of Medicine report entitled To Err is Human, Building a Safer Health System. This landmark report stated that medical errors cause between 44,000 and 98,000 deaths every year in American hospitals, and over 1 million injuries to patients. This publication marked an inflection point in the recognition of the perils and prevalence of medical errors in hospitals. In today's episode of the podcast, we will discuss medical errors. Where do we stand today, and what can we do to continue to make care for our patients safer? Our guest is Dr. Nitin Puri. Dr. Puri is a critical care physician. He is a division head for critical care medicine and the co-director for the Center for Critical Care Medicine at Cooper University Health System in Camden, New Jersey. He's an associate professor of medicine at Cooper Medical School of Rowan University. Dr. Puri is a recognized clinician, educator, and researcher with a special interest in medical education, medical errors, point-of-care ultrasound, and mechanical support. Nitin, welcome back to the podcast.
Sergio, thank you for inviting me back.
Well, we had a conversation on the same topic almost 5 years ago as we were talking. A lot has happened since, but I think a good place to start would be if you could tell us, why do you think this is an important topic for clinicians at the bedside?
Well, I think all of us make errors. And how do we deal with them psychologically, and how do our patients handle it, and how can we help our patients get through that process and help ourselves get through that process?
One of the things that I always appreciate, Nitin, is that the sign of intelligence really is our ability to change our mind and to learn new things, right? And we talked about this back in 2018. So my next question is, since we last talked about medical errors, what is one thing that you have changed your mind about or learned about this topic?
Yeah, that's a great question. So since the last time we spoke, there was a global pandemic, and fear and panic had gripped our subspecialty pretty substantially. And that definitely led to errors. And it also made me think and reflect at that time, what can I do as a bedside clinician to create an environment where we can talk about those errors openly. And it was actually a book you had recommended to me, the Amy Edmondson's book. I know she's been a guest on your podcast, and I think creating psychological safety in the critical care environment is one of the fundamental tenets of what we do, to recognize that failure is common, and how we respond to it is more important than failure occurring.
Perfect, and I do believe it. We'll talk a little bit about it. That psychological safety is a concept that obviously not only applies to dealing with failure and medical errors, but also applies to being a high-performing ICU. And I would also say that between 2018 and today, that is a word that has become a much more frequent part of my lexicon than it was before. As some people who might be listening know, I was your fellowship program director many, many years ago. And I don't think that I ever mentioned that word during your critical care and pulmonary fellowship training at all.
Yeah, no. I actually don't remember seeing you much during my training.
Well, that's an indictment on you. I was always there. So as we move along with the topic, I think it's always good to start by aligning expectations and making sure everybody's on the same page. So why don't we start with some definitions? I think a lot of times people are talking about different things, but using the same terminology, maybe with a different fully understanding. So, what is a medical error?
Yeah, that is, I think, definitely most important. Defining what is happening is very, very important. So a medical error is any error that occurs in the delivery of medical care, whether harmful or trivial.
And I think it's worth pausing there and emphasizing that a medical error does not require to cause harm to be considered a medical error, correct?
Yeah, that is correct. And I think that that's very important because there are further definitions, which, I think we'll talk about. And, medical errors that cause harm, go into the next category, serious medical error. So that's a medical error that causes harm and has substantial potential to cause harm. And that's very different than a medical error. But, addressing errors, thinking about them, reflecting upon them, hopefully will prevent a serious medical error.
Correct. And I think that what I was trying to also articulate is that when we think of medical errors, we should really be focused on process of delivery of care as opposed to the outcome. And I think this is true for so many decision-making approaches, is that we think of the outcome too much, but outcomes are important, obviously, but ultimately the only way we can learn is by focusing on the process. Because if I'm lucky, I might have a good outcome, or I might follow the right process and have a bad outcome for other reasons, and I wouldn't be able to learn if I wasn't focusing on, was the process done correctly?
Yeah, I think that that's actually really interesting because one of the medical errors since the Errors Human Report came out in 2001 that's improved substantially in the United States is the decreased incidence of hospital-acquired infections. And there's two pathways that are going in hospital-acquired infections in the field of critical care. One pathway is we focus on having a quality process to prevent hospital-acquired infections. And if we do have hospital-acquired infections, we try to understand why they occurred and think about them. And another pathway is it's even led to definition changes. For ventilator-associated pneumonia is gaming the system, or drawing less cultures, and that is the wrong way to address a error or a problem. What you want to do is improve the quality of the system, even if you go through a tough moment, because that will produce the quality outcomes, and that's the type of place you want to be delivering care.
Absolutely. So I think it's really about focusing on how do we improve our process in order to be more likely to deliver safe care. So the next definition I think that often is thrown around or category is an adverse event. How would you define that?
Yeah, so adverse events is any injury that occurs due to medical management, and it can be broken up into a non-preventable adverse event or a preventable adverse event. And a non-preventable adverse event is caused by medical care without any apparent error. So an example would be somebody is on a heparin drip, they're anticoagulated for whatever reason, and then they have an intracranial hemorrhage. If they were supposed to be on the heparin drip, the dosing was correct, at least to our knowledge, it's unclear to us why the bleed occurred. That would be a non-preventable adverse event. While a preventable adverse event would be, the bolus was too high and that caused the bleed, or the dosing was too high and that caused the bleed.
I think it's important because there obviously are known risks with many of the treatments that we implement in the ICU, and people have multiple comorbidities, and every treatment has a risk, right? And sometimes these are non-preventable, and understanding that and understanding that maybe the process was the right process in that patient is important, because if we were to change it just for the outcome, we could actually put more patients at danger. Now, we talked about the relationship of process to outcome, and how sometimes you might have no harm in the patient, but still a medical error. What's a near miss?
Yeah, so a near miss is an error in care that has substantial potential to cause harm, but does not. Either because it's intercepted or because it unexpectedly causes no harm despite reaching the patient. So a near miss is luck, and luck cannot be your strategy. And those should be treated as sentinel events and dissected and understanding the root cause of why they occurred to try to prevent something like that occurring again.
And I guess in some circumstances, a good process could create a near miss if you intercept it before it reaches the patient. Is that correct?
That is correct. A good process would allow you to catch. Now, wouldn't necessarily, hopefully it's not a near miss or get that close, but, let's say, at our facility or our colleagues, before we do a procedure, we call a timeout. So it's clear to us that when we're putting a central line, we're putting it on the side we want to, and we've consented the patient's family. So we're not getting ourselves into a situation where, the horrific stories of doing surgery on the wrong limb or something like that.
Perfect. So now that we've defined some of the key elements of what a medical error is, what's a near miss, what's preventable, what's not preventable, let's talk a little bit about the scope of the problem, Nitin. And I did mention in the intro the Institute of Medicine to Err is Human report, which was based on one of the landmark original studies on medical errors, which was the Harvard Medical Practice Study. They quoted up to maybe 100,000 deaths in hospitals and 1 million injuries back 25 years ago. What do we know today? Are medical errors a leading cause of death? What does the recent literature suggest in terms of what has happened or not happened over the last 25 years?
Yeah, I think it's important to digest the literature and understand that medical errors and how we understand the magnitude of them is epidemiological based work. So you go back and analyze records, and then you extrapolate going forward. There was a very controversial but also thoughtful piece that was put out that analyzed records from North Carolina in 2013, and I think the study came out in 2017, that said approximately 250,000 people died of medical errors in the United States every year. That would have put medical errors as the third leading cause of death in the United States. And then the study went on to say, which is important, but as a clinician who does fill out death certificates, as they say, and likely the number is even higher than that because medical error is not even put on death certificates where we can directly attribute death or harm due to a medical error. So I guess what I would say is that the magnitude of the problem is difficult to quantify, but if you were to look granular at studies that have come out since the Harvard Medical Practice Study in the early 90s, including more studies by that same group at other places like in Utah and Colorado, there are a lot of medical errors which occur. And there is significant potential for harm. And I think anyone who practices knows it's an issue. And that we still have a tremendous we still have a lot of opportunity to improve our care.
And I think an important point, like you mentioned, the study that I think was in BMJ by Macquarie that reported it might be the third cause of death in the United States, that every report that's been published recognizes that because of limitations due to the methodology, we're probably undercounting serious medical errors. Furthermore, a lot of medical errors are recognized because people report them, and we know that reporting is also something that probably could be a lot better, and we'll talk about that a little bit later. So in summary, it really seems like it is a real problem, and like you said, it happens probably every day in hospitals around the country, right?
Yeah, I mean, I don't think we can even say every day. I think, I think a good article to talk about would be that recent New England Journal of Medicine article. It's, I mean, 1 out of 4 admissions seems pretty reasonable number to cite for medical errors.
And you want to mention a little bit about, so this was recently reevaluated, and we'll link all these articles in the show notes, in a study that was, I think the original group was also from Harvard, the medical practice study. It's a kind of a continuation. Any comments from what we learned from that, the safety of inpatient healthcare?
Yeah, so that's a really important study. And although it's not specifically focused on critical care medicine, it is inpatient practice. And 1 out of 4 patients had medical errors. It was 7 hospitals of varying sizes. Actually, if I'm not right, maybe it was 11 hospitals of varying sizes. And I think 2 hospitals greater than 700 beds, all the way down to hospitals less than 200 beds. And I think they sampled something like 2,800 records, 9 nurses reviewing the records, then adjudicated by 8 physicians. This group has been doing this methodology for now, 20, 30 years. So I think they have a very clean way of looking at medical errors, and they're continuing trying to refine it. And, 7% of errors with serious harm, and, 0.2% leading to, I think, death. 0.2% of 2,800 is not a significant number, but, if you think about the number of people who are hospitalized in the United States, then that number starts to grow substantially of the number of people who've possibly been harmed. So that study was very, very insightful and well done.
And the other thing I recall that I think is important for our discussion today as well is that you mentioned that 1 in 4 patients, so 25% of admissions, are associated with a medical error during their hospital stay. And of those, again, one out of 4 of those errors, or 25% of those, were preventable. So that's really, I think, where we should really focus on as clinicians is, okay, let's make sure that we do everything we can to avoid preventable errors, right? And then we can try to figure out, okay, what else can we do to improve the delivery of care to prevent adverse events and other things, or minimize them.
100%. I think that there are some simple strategies to address preventable errors. And one of the simplest is communication, clear, direct communication, making sure that those you're communicating with understand what you're saying, and they can, you can follow through on their plan, and they can follow through on your plan to care for patients. That goes along with a clean and effective sign out, and multitude of things.
So before we dive into more interventions that we could do to move the needle in the right direction, let's dissect a little bit more the types of failure and the most common types of medical errors that we see in the hospital. I believe, Nitin, that unfortunately critical care and medicine in general have a very bad relationship with failure, right? We have been brought up and educated and really just judging failure as always bad. And it's led to, I think, a lot of blame throughout healthcare, which is not a very effective way of creating psychological safety or of learning. But the reality is, when you really look at failure, there's a lot to be learned from failure. Not all failures are bad, and not all failures are blameworthy. So when you think of failures of mistake, how would you classify them?
Yeah, that's a good point. So, I think there's three ways that I like the way Amy Edmondson had quantified them or described them: preventable, complex, and intelligent. Preventable error is a deviation from a process. I decided, I trained in the era of using ultrasound to place a central line. I have now decided to put the central line without the ultrasound because, I didn't want to wait. And so I placed the line and I caused a pneumothorax. That was a deviation of practice, and that's a preventable error. A complex error is a system failure. I think a common and important complex error is the workaround, which is, I go to pull Versed because a patient needs an MRI and they have anxiety. And when I go to pull Versed, I instead pulled Vecuronium. And that's a pretty important case that happened in the past year with a nurse in Tennessee. And the reason that she was pulling medications like that without safety checks was it was a workaround. The medication dispensary machine was not working appropriately for the care that needed to be provided. And so everyone knew that you just bypassed the safety system, and that had become a normal workaround. So that is a system failure. And then intelligent failure is the failure that I think the researchers themselves may be a bit frustrated with, but I think we celebrate in medicine. And it's also, a bit of frustration in medicine that negative trials aren't published, but that's when a clinical trial is negative, but it provides insight into, medications that are being used and why they're being used. And, we had a lot of success with that with COVID, the adaptive clinical trials, saying, okay, Plavix doesn't work for a COVID patient, but, modern anticoagulation works for patients not in the ICU. And those were adaptive clinical trials, and they help inform our practice and help people along the way.
Yeah. And I think it's important to emphasize this because we can't always categorize failure as a bad thing. I believe that we should definitely try to prevent preventable failures, right? Like if we have a protocol, we should follow the protocol. There's a reason for that. And deviations from that require accountability. And those would be the ones that are maybe blameworthy, because I think it's also important to investigate why was the protocol broken. And there's a lot of other reasons that we may talk later. Complex, I think you talked about the workaround, but also in our world, complex failures can also relate to just the severity of interactions between organ failures and the therapies we're doing and the complexity of critical illness and multi-organ failure. And perhaps despite everything that we do, the patient dies, and that's seen as a failure, but it was really due to the complexity of the situation or the system. And with intelligent failure, I think that another example that comes to mind that I think is very important that goes outside the context of clinical trials is when we are trying to improve delivery of care and we do a small pilot, right? We say, well, maybe if we did things this way, it would be better. We do a pilot and we realize that, no, actually things are worse. And we stop there before we have made a big change for everybody. And that is also, I think, a intelligent failure. And those should be celebrated. I agree with you, Nitin. I think they should be celebrated because they are giving us insight into improving care. And I think we need more of that, obviously, at the bedside and in the ICU. Now, the next thing I wanted to ask you about, Nitin, was the types of medical errors that are commonly described, or one of the most common medical errors that we see in the hospital setting.
Yeah, almost uniformly in most studies, medication errors are the first medical error that is cited. Delivery of medication, wrong dose, wrong patient. And so medication errors, and now with medication shortages, it's become, even more complex. So medication errors really is number one. Then after that, surgery procedural related errors, although there's been some disagreement about that. I think around surgery itself, perioperative, during the surgery, post-surgery, but there's some of the conversation has been, it's not necessarily been during the surgical event, but post-surgical, and therapy that's being provided has not been what is advised. And then, patient care errors, something we, I think, as intensivists, many times we're at the bedside and we're familiar with, whether it's diagnostic, not basically recognizing clinically deterioration and what needs to happen and intervene. And then, the classic hospital-acquired infection would be something that is actually easily quantifiable, and a lot of work has gone on to that since Daeris Human came out in 2001, and there's been substantial improvement in that realm. I think mainly because it's been able to be quantified and attacked.
And I guess another category that maybe not in our world, but in our ED colleagues' world is very important is diagnostic errors, right? Where somebody comes in with a bad headache, they do a CAT scan, it's negative, but they never did the LP, and then they have a massive secondary subarachnoid bleed or something along those lines, or somebody gets sent home with chest pain and they actually had an acute MI. So these are all, I think, like you said, important errors. Now, one of the things that I understand, and I want to hear your comments, is you did mention that with hospital-acquired infections, just the fact that we talk about it all the time, I think, has made us much more aware, and it's been demonstrated. I mean, obviously, Peter Pronovost and others have done, landmark work on demonstrating that abiding to a process that it's evidence-based can decrease the incidence of infections dramatically, right? So there are processes in place. Some of these may have been abandoned or worked around during COVID, but there's a lot of opportunity to bring those back. But the other thing that I wanted to ask you about is we always complain about the EMR. Yet my understanding, Nitin, is that the literature is clear. Computer physician order entry, which is part of the EMR, and the EMR in general have improved safety for patients and have decreased errors dramatically. Is that the way you read the literature as well?
Yeah, that's actually, if you think about the original Harvard medical practice study, there's been substantial improvement in care delivery, and electronic medical records have played a role in that. There are, have been unintended consequences, the copy and paste function. And I think that leads to a different type of medical error. And that was probably different from what we saw in the pre-EMR. But the EMR has definitely improved care delivery. And I don't think, for me, I'd be curious to see if anyone had other thoughts on that.
Perfect. Now, what are some of the common causes of medical errors? Now, we talked about, before we started recording, obviously, that we're going to try to focus on what individual clinicians can do and talk a little bit about system solutions. But when people have looked at medical errors in general, there seems to be some themes that are recurrent. Could you talk about some of those common causes?
Yeah, I definitely hit on the first one, is communication. So I think that clear and direct communication is really a huge, important point in medicine. And we don't, unfortunately, spend enough time, I think, teaching that at the bedside when people are coming up. So I really emphasize that. And then communication between yourself and the nursing staff, yourself and your colleagues. So I think that that's definitely a big one. But that's not the only one. There definitely a lot of concerns about inadequate information that flows between people. There's patient-related issues as like you don't have appropriate identification, you don't get consent, and something that comes up all the time in our world, and especially during COVID, is are we appropriately staffed? We see appropriate staffing ratios, people care has improved, but that's not most of the time what I've seen as the cause. And then technical failures, which are common. We use a lot of technology in our world, and have devices failed, and how do we handle those devices? But I think, again, I keep on going back to communication, because I think communication goes back to inadequate information flow. And so I'm very particular about picking up the phone and speaking to people and making sure that I understand what they are saying and that they understand what I'm thinking. And even if there's a moment of frustration, I try to, because I recognize that'll hamper the flow of information, try to make sure that the patient's at the center of the conversation and that the frustrations can be dealt with later.
And I think with regards to communication, one of my favorite quotes, I think it's from Bernard Shaw, is that the biggest problem with communication is the illusion that it has occurred, right? And a lot of times people only measure the effectiveness of their communication based on what they said. And if it wasn't understood, like you said, or if it was misunderstood, it definitely will lead to an error. So making sure that we're verifying, that we're providing the right information, but they're also verifying that there's clear understanding of what we're trying to communicate. And it's very interesting that a lot of the things that you mentioned, Nitin, have all been addressed, and I wouldn't say solved, but they have all been addressed and worked upon by aviation, right? So communication through checklist, and for process procedures that make sure that everybody's clear, technology failures and redundant systems. These are all things, adequate hours of work and staffing. There's all things that our aviation partners have been working on for many years, and that I believe there's still opportunity for us to do a little bit better.
Yeah, no, I agree 100%. And I think that we, patients are very complex. There's a multiple patients that we're taking care of. And, has information been adequately given to us to be able to care for the patients? And are we in the psychological space to receive that information and move on it going forward? And that's the utility of the checklist. Some very, very important things are, moved out of the way. And so you can focus on, perhaps the unique problem at hand. I have a lot of respect for the safety that's gone on in the aviation industry. And I also think that, other professions where you have to make split-second decisions, whether it's, firefighters or the police, and then having to look back on that decisions can be very difficult and brutal. And I think that we fall into that category at times.
Now, I have to ask you before we move on, as a cause of medical errors, because it's something that, especially post-COVID, but even pre-COVID, has been a topic that is prevalent in healthcare and in critical care. Does burnout lead to increased medical errors?
Yeah, that's a great question. Burnout is such a vague topic, and it's a catch-all phrase that it's hard for me to directly attribute it to it. What I can tell you is, if you've made a medical error, that will lead you to burning out. I think the causation, that's pretty clean, that'll lead to that. But as somebody who is, burnout leads you to being disengaged, and then that, you will definitely have more of a chance of creating a medical error. If you work in a space that doesn't have psychological safety, and that makes you burn out, that will lead to medical error. But burnout itself, I have not seen anything directly.
Okay. Well, I think that's a perfect lead way to our next topic, which is really how does the individual clinician listening to us improve their role in making care safer. And before we go into what people should do, since you mentioned it, maybe we should talk first and about the effects on the clinician who makes the error, right? So we always obviously are very concerned with when we have a severe medical error, a serious medical error, on the implication it has on the patient and their family. But there's also something described as second victims. Can you talk a little bit about that, Nitin?
Yeah, this is a really important and big topic for us as intensivists. When you make an error, you need to disclose to the family and being supported to be able to disclose and be in a supportive environment is very important too. But even after you've disclosed, you yourself feel awful. And you may be beating yourself up and really taking a lot of, psychological blows that may be internal or from others, people whispering in the hallway saying, oh yeah, do you see what happened to him? And it's very, very important to recognize there is a second victim when a medical error occurs. Something possibly bad may have happened to a patient, but there's also another human on the backside who committed the error. And most physicians or most healthcare practitioners got into this to care for others and look out for others. And when you've caused harm or inadvertent harm to somebody, the toll on you can be tremendous. So that's, the second victim. And, to link back into the burnout, that if you are not able to engage that moment as a colleague or as a clinician in a manner where you can, I don't know if you'll ever be able to make it something positive, but make it a moment of growth and resilience because you were trying the best you could, you were being thoughtful, you made a mistake or the system wasn't appropriate, then that will lead people to not want to practice medicine, not just critical care.
For sure, and I think Nathan, like you mentioned, right, recognizing also the impact it has on the individual clinician should make us more empathetic towards our colleagues, and to be more supportive and less blaming, and more asking how we can improve the system and understand what really happened. And one of the topics you mentioned at the beginning, the case of the nurse in Tennessee, and I think that correct me if I'm wrong, but that went to, I think, a criminal court, and obviously resulted in, I think, a significant harm on the nurse. But except for people who do it, I mean, with a criminal intent, I don't think any healthcare worker goes to the hospital thinking that they want to harm another patient, right? That's not what we went into healthcare. So I think that maybe depenalizing some of these medical errors and really trying to find ways of improving the system and giving people the tools and knowledge that they need to provide the best possible care is really the way to go. So what would you recommend for the individual clinician as step one in improving patient safety and how we deal with medical errors?
It's funny, but to err is human, right? That's the 2001 report. We all make mistakes. We make them every day. And to embrace that an error is the starting point in a conversation, not the end of a conversation, and to expand, to dissect that error, open it up, and be allowed to think about it and see why it occurred is very, very important. So the individual clinician, if I was to make one point, it would say is that be kind to yourself, that voice in your head. Don't be angry with yourself. And if you have a colleague who makes an error, be empathetic, because the next time it could be you, and be supportive. And with the families, sometimes the families are very, very angry at times. They're going to be angry. This is their loved one. We're a very specialized group of medicine, and they expect us to be perfect. The patients are so sick, so if an error is made, it can be catastrophic, even if it's a small one. But allowing them to have the space to be frustrated and being able to put it in context is important. So resilience is what I would say, is understand how to build resilience in your own life, and what is it that you need to build up that, so you have that psychological ability to handle mistakes.
And what about, you did mention the families, and any suggestions or tips on how to best disclose medical errors to patients and families?
Yeah, I definitely have a couple suggestions. So I think that after error has been made, it's important to try to deal with the outcomes of the error. And medically, if you are not in the psychological space to be able to do that, if you have a colleague or somebody who can help you out in that moment, lean on them and be transparent with them. Say, listen, I'm just not, I don't have the headspace right now to deal with this, and I just need to take a break. The ability to express yourself open and honest to another colleague, so the patient can still receive care. But after that point is being honest with the families without self-flagellation. For good reason, is some historical distrust of medical providers in this country. So I try to be as transparent as possible, but I think when I was a younger clinician, I would just be like, yeah, I did it. I made a horrible mistake. I'm sorry. And that's okay, but that's you venting to the family, or looking for the family to comfort you in a dark moment. And that's what you don't need to do. You need to be a professional and say, listen, I made a mistake, or a mistake was made that possibly led to harm, or did lead to harm. I want to tell you that I acknowledge it, and as an institution, we acknowledge we're not trying to hide anything, and we'll be as transparent with you as possible. It is fascinating now that in most of America, the patients and the patients' families have access to the medical record. So at times people will come and approach you and say, I don't understand why this is said. Can you help us understand? So having a very open relationship with the families is important.
And I think that what I'm hearing here, Nitin, is that be very clear and concise with non-medical jargon. What happened? What is the implication for the patient? And I think also very important to list the steps that we're taking to remediate or make things better, right? And the follow-up that they'll have. So being, just like you said, clear, and really thinking about providing the right information in a compassionate way, but like you said, being very precise with what you're saying.
Yeah, and disclosing, apologizing, I think are important. I think any clinician thinks about the medical legal ramifications, but at that moment, what you need to do is just be transparent and truthful, and whatever may come, may come. But we all took the Hippocratic Oath. Our duty is to protect, and this is common, right? I mean, the Harvard Medical Practice study from, I think, earlier this year, it was in January. It's 1 out of 4 patients. This is not a rare occurrence. So I think that we as a practice, or as clinicians, need to understand that it's common, and we make mistakes, and be transparent about it. I also think that I like what you said about medical jargon. sometimes we will go into our heads and use a lot of medical words, but explaining in language that the patients can understand is important.
Yeah. Some would argue that at a fifth grade level probably is where you should target if you're explaining something like this. And I believe that also the other comment I want to make, Nitin, you mentioned the medical legal. I think the literature that's available is quite clear that transparent and timely communication will decrease the likelihood that you will be involved in legal problems. It doesn't obviously prevent it 100%, but I think it definitely will decrease. And actually, the University of Michigan has had a program that they're self-insured, and they have a very robust and a very active process of disclosing medical errors in the hospital. And since they went that route, they have noticed that their legal issues have decreased significantly. So I think that silence is probably much more likely to lead to malpractice issues. And like you said, I mean, we took an oath, and we should always be very, very straightforward and clear with people on what's going on with their loved ones.
Yeah, we at the hospital I'm at, Cooper Health System, we have a standardized note for disclosure, and then you're supposed to notify your chief of service if a disclosure has been made. And then there's a process you follow, which is on the back of the badges that, an extra card that I give to my faculty, advanced practice providers and fellows, because what you want is, in that moment of panic, you want to have a playbook that can be followed and be transparent. In Michigan, they published literature on what they've done, and Cooper is similarly self-insured and follows a similar playbook. And it's, as institutionally, it's I'd like being in an institution like that.
Excellent. Well, we talked a little bit about some of the important aspects for the clinician, including being kind to yourself and recognizing that clinicians are also victims of medical errors, especially when they happen, to themselves, and how to deal with that. We talked about the importance of being kind to others and being more curious about medical errors with the intention of learning from them. And we talked about disclosing medical errors to patients and families. You're a leader of a critical care division, of a critical care center. As a leader, what are things that you're focusing on to try to improve safety for our patients and decrease medical errors?
Yeah, one of the advances that I've seen over my career is the system for reporting errors, and for errors then to be thought about in a global manner. Like there's a process around it. So, at my institution, it's called the EARS system, and I think it's important to, if you are not in a place that you're able to report errors in a standardized fashion, and those errors can be queried and be thought about, then to speak up and say, listen, I've heard that other institutions do this. How can we gain access to an anonymous way to report errors? And I also would like to know the outcomes of those conversations. I think also as a leader, a true leader facilitates conversations or things that, quote unquote, a leader may not want to necessarily hear. And that will allow, if the dirty laundry is aired, it allows conversations on how to improve practice, because patients are at the center of the conversation. And then I think there's important to know the difference between, as a leader, and also this is very important for a bedside clinician, the difference between speaking up about a problem, being thoughtful, and complaining. And that if you are speaking about a problem and you've shifted over more to just complaining, that the concept of psychological safety allows you to speak up, but it doesn't necessarily protects your right to speak, but it doesn't necessarily protect your right to, speak illy of others or cycle into a negative spiral. So as a leader, to promote open and honest discourse, but also for your colleagues to know that if you're going to go into a unproductive cycle, that you're as a leader, you probably stop that. But what the worst thing you can have is have a meeting, an important meeting, and no one speaks, because that's a sign that people don't feel safe to speak, or when they speak up, it's useless. And if that's what's happening at you or your institution, you need to re-engage to see why you're not hearing other people's voices in the room.
Absolutely. And I think that another important aspect of this is that you did mention that we all are part of the problem. Every clinician will commit medical errors. So I believe that short of just complaining, they should be part of the solution, right? And this is something that actively should engage everybody in trying to make care better. And that is part of being in a high-performing critical care team that requires psychological safety as its first ingredient. But I agree. I mean, that at the end of the day, we can't solve things unless we're working together as a team in the ICU. Nitin, this is obviously a super important topic. I appreciate you taking the time to talk with us about it. We'll have links to the articles you mentioned, to some other resources. You've been on the podcast before, so you know that we like to close with a couple of questions that are unrelated to the clinical topic, but that kind of tap into your wisdom. Would that be okay?
Yeah. No. My wisdom is on short supply, but I'll do my best.
So the first question relates to books. Are there any books or book that has influenced you significantly recently, or that you have gifted to others recently?
I would say that I enjoy fiction and literature. So I really enjoyed reading Pachinko, and I think it became like an HBO teleseries or something like that. But it just the history of basically Southeast Asia during World War II, and I've gifted that book to a couple of people because it's just an amazing read. But it's also an insightful way to understand that part of the world, or the part of the world that I'm not from.
Excellent. Second question: what do you believe to be true in medicine or life that most other people don't believe, or at least don't act like they believe?
I don't know if everyone embraces this, but it's something that I sort of live my life by, that problems are opportunities. Like, if I have a problem or there's failure, my immediate reaction is like, oh my God, this is terrible. And then I take a step back and be like, well, how do I turn this around to make it an opportunity? And, career-wise, that's, we had patients with ARDS. We were transferring out of the hospital for ECMO, and I said, this is an opportunity to build an ECMO program. How do I do that? And it has been, it's really been a useful tool for me.
And I think that also obviously very, very applicable to what we're talking about today. Any medical error, any failure is an opportunity to learn how we can do things better for more patients. And I think that humility, that growth mindset is something that we all need as clinicians, but also as leaders. And the last question would be, what would you want every intensivist, an APP that's listening to us today to know? Could be a quote, a fact, or just a thought.
I would want them to know that you are my friend and a very thoughtful person. And it's been a tremendous honor and opportunity to know you and listen to you as the years have gone on.
Well, thank you very much. Same here. I really always enjoy spending time with you, whether it be on the podcast or in person. appreciate you sharing such an important topic with us today, and looking forward to having you back.
I appreciate it. Sergio, you take care.
Take care. Thank you.
Thank you for listening to Critical Matters, a sound podcast. Make sure to subscribe to Critical Matters on Apple or Google Podcasts and share with your network. Sound's transforming the way critical care is provided in hospitals across the country. To learn more, visit www.soundphysicians.com.